Now we're going to be talking about the pediatric disorders with a genitourinary alteration. This is the anatomy of the genitourinary system in a little girl, and she looks about age 4 to 7 maybe years of age. So you can it tells you a little bit about the placement of the kidneys and the ureter and the bladder. There are some differences in the genitourinary system. Complete maturation of the kidney occurs usually between 6 and 12 months of age, and before this time the filtration capacity of the glomeruli is reduced, so urine is voided frequently and has a very, very low specific gravity because of that glomerulus filtration rate being reduced. So it's like they can't concentrate urine. Fluid constitutes a larger fraction of an infant's and small child's total body weight. The kidneys are less efficient at regulating electrolyte and acid-base balance and eliminating some drugs from the body. The maturity of those renal structures predisposes the infant to dehydration and, of course, fluid volume excess. Bladder capacity increases usually from about 20 to 50 mLs at birth to about 700 in adult. The innervation of the stretch receptors in the bladder wall does not occur before the age of 2. So that kind of gives you an idea that when that at least has been matured, you're going to have that child feel that sense of fullness. So, and before that, they won't. The urethra is shorter in children than in adults and may contribute to the frequency of UTIs that you especially see in children. Kidneys are more susceptible to trauma in children because they do not have as much padding as you and I do, as we all know. Well, especially me. I don't know about you, but especially me. So some of the diagnostic tests and assessments of the renal system that you'll see, of course, is the urine specimen for analysis. It can be a clean catch or it can be a sterile. IVP, radiographs of the kidneys, ureters and bladder, renal bladder ultrasound, cystograms, CTs, voiding cystourethograms, and MRIs. On page, this is chapter 20 in your PEDS book, The Child with a Genitourinary Problem. And on page, let me just refer you to it real quick, is the common labs and diagnostic tests are on page 456 if you wanted to follow along. But I think it's important that you have a basic understanding of what's normal for specific gravity. And if it's high, what does it mean? And if it's lower, what does it mean? The pH sometimes is altered by diet. Usually it's 4.5 to 8. Glucose, detection of glucose in the urine. We should not detect glucose in the urine, and we really want to make sure that we do just a simple urine dipstick, especially if the child has been having problems with enuresis, nocturia at night. Make sure they're not a diabetic. We want to check for ketones. And children are more prone to development of ketouria, so we want to make sure that that's negative. Leukocyte esterase, that's just the enzyme that is released during the white blood cell breakdown, and that should be negative. If it's positive, it may indicate that there's a possible UTI. Are nitrates produced by select bacteria? That should be negative, and when it's positive, it usually means that there's some bacteria in the urine. White blood cells, usually seen with infection. Urine culture is usually indicated for that. Red blood cells, it's very normal in menstruating females, but it could mean that there's trauma, stones, infection, or glomerulonephritis. Bacteria, there should be none in the urine, and if there is, it's indicative of a UTI, and a culture should be done to see what kind of organism and what sensitivity there is for which antibiotic. Casts are just WBC casts and red blood cell casts that originate in the kidney tubules. Usually indicate if they're present pyelonephritis, glomerulonephritis, some kind of renal infarct, collagen disease, interstitial inflammation of the kidney, and urine, of course, urine culture and sensitivity, presence of bacteria. It should be negative or less than 100,000 colonies per ml of urine from the clean catch or a sterile specimen. Usually, if it's indicated, there's isolation and identification of pathogens in that urinary tract, and then there's identification, of course, of antibiotic sensitivity. Serum studies, of course, will BUN. That's the end product of protein metabolism, blood, urea, and nitrogen. Nitrogen's that end product, and usually increases in renal insufficiency. Your serum creatinine is byproduct of muscle metabolism production, and it's usually constant as long as the muscle mass remains constant. And it should be assessed before giving any kind of nephrotoxic type agents. And of course, as you know, it increases in renal insufficiency. It goes into the different radiographs, your kidney, ureter, and bladder, cystoscopy, and they go up and they examine the bladder and the lower tract to see if there's any tumor or stones. Of course, CT of the scan, CT scan, to check for any renal tumors, voiding cystogram, voiding cystourethrogram. It detects reflux of urine into the ureters and its severity, so that at that VE junction we talked about the other day. Renal ultrasound assesses the position, the size, the contour of the kidneys and the ureters. And any kind of urodynamic studies can be done for any voiding dysfunction and any abnormal urinary tract problems. And that's on, as I said before, it's on page 456. It starts there. These are the serum blood tests that may be done. We've already talked about BUN and creatinine, and we haven't talked too much about serum electrolytes, but as you remember, the functions of the kidney is the production of renin, which helps with the regulation of blood pressure, and release of renin is stimulated primarily by the decreased pressure in the afferent arterioles of the glomerulus. Remember also that the kidney functions to produce erythropoietin, which stimulates red blood cell production by the bone marrow. And it also metabolizes vitamin D in its active form, which is important, especially with calcium. So those may be some red flags for us as we look at our serum blood tests, but know that there are a lot of other differentials that you have to think about as well. Okay. We're going to start talking a little bit about urinary tract infection and vesicoureteral reflux. It's that word I can't hardly say. Anyway, UTIs. UTIs, as you know, we've talked, hopefully you've listened to the lecture on Chapter 69 in IGI, but it's caused by bacteria that ascends from the outside, the urethra, into the bladder. And from the bladder, bacteria may continue to ascend into the upper urinary tract. Usually fecal bacteria is most common cause of UTIs, and that's probably approximately 80%. So here are some of this slide goes over some of the anatomical and physical factors that predispose to urinary tract infections, and they include females because of the short urethra, which provides a real ready access for invasions of different types of organisms. The males, there's increased incidence in uncircumcised infants, especially younger than 1 year of age. There also could be the child could be predisposed because of urinary stasis, or the vesicoureteral reflux, sexual activity in adolescent girls, any kind of urinary tract obstruction, and constipation in the child can also cause a UTI. This slide just goes over the different signs and symptoms in the infant versus the child. So we'll first start with the infant. Fever, they may have hypothermia in the neonate. Irritability, difficulty urinating, change in urine odor or color, poor weight gain, feeding difficulties. In our child, the clinical manifestations may be abdominal or suprapubic pain, voiding frequency, voiding urgency, difficulty urinating, new or increased incidence of enuresis, that nighttime bedwetting, and the child may or may not have a fever. Under our diagnostic evaluation, we're going to get the history from the parent. We'll do our physical exam, do a urinalysis, and do a urine culture and sensitivity. On our therapeutic management, we'll eliminate that current infection, identify any contributing factors, especially if the child maybe has constipation, predisposes him or her to UTIs. We want to prevent urosepsis, and we want to preserve that renal function. Very, very important. So our nursing considerations, we want to monitor I&O, we want to observe for signs of dehydration in the infant and the child, administer antibiotics as ordered, obtain daily weights, encourage frequent voiding, especially in the toilet-trained child, because as children, they'd rather play than pee. Or poop, so want to make sure that we remind them, especially, I love how kids always, kind of dance around, and you can always tell the hand goes right down to the genital area, and that they have to go potty, but they just don't want to take the time to do it, so it's really cute. Anyway, we also want to encourage increased fluid intake, very important, and it's important to educate the child and family as well. We're going to take a break right here, and we'll continue on another web link for the vesicoureteral reflux. Okay, talk to you in a minute.